I guess a few of them have actually seen or have got patients who've actually been doing have had liver transplantation. So I put this slide on most of my liver transplant presentations because we'll never say goodbye when we can actually pass on the gift of life, and liver transplant is a perfect example for that. As we know, there are different types of liver transplant cadaver and the living donor transplants where we can actually save somebody's life by giving the transplantation. So some of you do recognize this the painting, I guess. Any shouts about what this painting is about? Okay, right. Anyway, we'll move to the next one. Another reason why liver transplantation has been successful, and particularly living donor transplant, is because, as we know, the liver is a segmental anatomy. We have 8 segments. So even if you disturb the left lobe of the liver, the right lobe is still working well. So we can actually take segmental lobectomies or hepatectomies so that we don't disturb the functioning of the native liver functionality. So that is another advantage that we have, where we can actually perform the living donor transplantations in the liver. So my talk will consist of these the few things. So we talk about indications of liver transplant, when we should do liver transplant and why we should do liver transplant. And more importantly, we also should know about when not to do liver transplantation and how do we optimize this patient before liver transplantation. What's the workup that we do, the pre-op workup, the multidisciplinary workup that we do before we do the transplantation. How do you evaluate this for the patient with liver transplantation? Some little terms that we use during the liver transplantation, like the warm ischemia time, the cold ischemia time, what are all these terms? So we'll go through that. And very briefly about liver transplantation. Now, mind you, I'm not going to go in details about the surgery part. We will discuss about how the plumbing happens. What ducts with their what arteries they actually first connect before going to the ducts. So few topics about few slides about those, and then more importantly, post liver transplantation complications, how to monitor these patients, and what are the chance of recurrence of these diseases. So why is it important? Because as we know, throughout the world, the liver diseases are growing in number. And this slide actually is from the UK, which shows that the liver-related mortality for patients who are under 65 is significantly growing in number compared to the other diseases, like, for example, the diabetes, or including the chest diseases or strokes or ischemic heart disease or circulatory disorders. All these disorders are reducing in number. The only disease which is actually growing in number is the liver cancers and the liver-related diseases. And we know the reason for that is obviously three main reasons. The alcohol consumption is not reducing in number. In fact, it's growing in number, particularly alarming in the Western countries, and also now catching up in the Indian population. And the viral hepatitis and B, as we discussed, hepatitis B is more rampant in the African countries. And also the bigger elephant in the room is the non-alcoholic fatty liver disease, or the NASH related chronic liver diseases, which are growing in number. And in fact, we see more of these bigger MACs, which is actually being the highest cause for the liver transplantation right now, apart from hepatitis C. And we know the spectrum, what happens when there is inflammation that happens that leads to the steatosis, leads to steatohepatitis, inflammation that leads to cirrhosis, and subsequently liver cancer. So once we know that the patient ends up having the stage of liver cirrhosis, that is an irreversible and progressive condition. And it's only a matter of time that some of these patients will end up having complications or decompensation, what we call, with ascites or encephalopathy or jaundice, or variceal bleed. So, and once we know that they achieve these kind of, or hit these landmarks in their journey, we know that there's a significant portal hypertension and it is a progressive condition. At some point, they may need liver transplantation. So I think it is very important for all of our physicians, whenever we see any chronic liver disease patients, don't wait for them till they get the stage of this end stage liver disease related complications like the ascites and the other decompensations. We should start sensitizing them about liver transplantation at a very, very early stage. If I I want all of us to take one message out from this talk today is that liver transplantation is a successful surgery, and denying them of not giving that option is robbing them of their important options for them. So I think it's important that all of us should understand that when these patients require, when the patients have reached a stage of chronic liver disease, we should give the option of giving the liver transplantation. Of course, not straight at that point. There are certain scoring systems which will go through it, but it's important to sensitize these patients that it is a progressive and irreversible condition and that they would at some point may need a liver transplantation. So a bit of a background about liver transplantation. As you know, the first person who's done the liver transplant, or the father of the liver transplantation, is Professor Stahls in 1963. That was the first ever liver transplantation which was done. Initial few transplants, as we know, have been unsuccessful, but after the introduction of the immunosuppressions, there's been a significant improvement in the survival rates. Now we talk about survival rates of almost about 95 to 98% for patients who do liver transplantation. But of course, these are patients who are not poor candidates like the very high MELD scores, like more than 35. Those may not have good outcomes. But otherwise, liver transplantation itself, the success rate is almost 95 to 98%. Okay, coming to the indications, I'm sure you all are aware of the indications: chronic liver disease patients, acute and chronic liver failure, and acute liver failure. These are the three main indications. Of course, the other thing which I didn't add over here is the hepatocellular carcinoma, or the HCCs, and also the storage disorders, particularly in the young population, the pediatric population. So if you look at chronic liver disease failure, which forms the bulk of the reason why we do liver transplantation, the cirrhotic patients, which is particularly parenchymal cirrhosis, or some of these cholestatic liver disorders, like in PSCs and in the PBC, metabolic defects like in, as we see in hemochromatosis, which led to the chronic liver failure, and also vascular disorders like the typical example is the Budd-Chiari syndrome and the malignancies. And in the acute liver failure setting, most often it is in the Western population, the drug-induced, the paracetamol-induced. And in the Eastern population that we see is generally the viral infections, particularly hepatitis B-related acute liver failures. Sometimes we do see cryptogenic or autoimmune hepatitis-related acute liver failures, but generally they present as a subacute liver failures rather than being the acute liver failures. As I mentioned, the majority of the reasons why people end up having liver transplantations is the chronic liver diseases, in particular the cirrhotic livers. And as we discussed, the most common reasons for cirrhotic patients are the viral hepatitis and the alcohol and the NASH related. And previously, a lot of patients who have been labeled as cryptogenic are actually are NASH patients. So majority of these patients, either the NASH or alcohol or viral hepatitis, is the most common reasons for the cirrhotic cirrhosis related chronic liver failure patients. And metabolic, as we discussed, the Wilson's hemochromatosis, and also cholestatic liver disease like PBC, PSC, biliary atresia in young children, particularly, and in PFIC, Alagille syndrome related cholestatic diseases. Vascular disorder, Budd-Chiari, giant hemangiomas. Giant hemangiomas are very rare, but Budd-Chiari, yes, we do see that. Malignancies, HCCs, hepatoblastomas. Okay, so another depiction to say that cirrhosis is the most common reason why we do the transplantations. The acute liver failure patients, or the acute liver failure, consider about 8% of the population, and cancer is about 15% of the population. But majority is the 50% or even 60% of the transplantations are done because of the cirrhosis of the liver. And acute liver failure patients with complications of cirrhosis, patients who develop, we'll go through all those scoring systems in a bit. But chronic liver disease patients, when they develop ascites, or if they have any blood loss and GI bleed, encephalopathy, liver cancers, refractory virus hemorrhage, or poor liver synthetic dysfunction, these are the common indication that we see for liver transplantation. And as I mentioned earlier, all the storage disorders, Wilson's disease, particularly in younger population, we do have to consider liver transplantation for these patients. Systemic complication of chronic liver disease like hepatopulmonary syndrome, yes, we consider liver transplantation, but for portal pulmonary hypertension, if they have significant portal hypertension, that itself is a contraindication, which will go through in the section where we'll discuss about when and why not to do a transplantation for certain categories of patients. So if they have HPS, yes, we should do, particularly if they are moderate to severe. But mind you that HPS patients post-op, you need to be very careful because they will have long-term weaning issues with the oxygen and stuff. But for the portopulmonary hypertension, if they have a severe portopulmonary hypertension itself is a contraindication to do a liver transplant. Now, coming to when to do a transplant for these patients. So generally, when we have refractory ascites patients, the median survival is 11 to 12 months. If they, on top of that, if they have SBP, the survival rate drops down to 6 to 8 months. And if they have a hepatohydrothorax, then it's about average 6 months. And if they have hepatic encephalopathy, 9 to 11 months. So this is the window period where you need to catch these patients before they reach the stages of refractory ascites. Once we know that they develop ascites and they're not responding to the diuretics, what we call refractory, that is a time when you have to start hitting the button and then get the transplant as soon as possible. Because once they develop ascites and then you start refractory ascites, or they develop SBP and then you start registering these patients for liver transplantation, the median waiting time for these patients for liver transplantation is 3 to 6 months, depending upon the blood group. And most of these patients, they fall off the radar, they fall off the waiting list, they die before they even get their list of the listing for the transplant. So it's important that we should sensitize ourselves and the patients that as soon as they have any kind of CLD, chronic liver disease, even before they even end up having any decompensations, we should sensitize them for the liver transplantation. Okay, so another thing, particularly in patients in African population, because we have significant amount of hepatitis B related chronic liver disease and HCCs. I think these are the highest risk group of patients with HCCs, where you should always consider these patients for close surveillance and also even consider liver transplantation based on the Milan criteria. So the African and North American blacks with hepatitis B, they have a significant risk of developing the HCCs. So we should do them on a regular surveillance program for these patients. So HCCs, you know that the Milan's criteria is what we generally use, which has been used for a long time, almost from 1990s. So they have an average 4-year survival rates of 74%. The 1-year survival rates are about 95%, and the 4 to 5 year survival rate is about 70%. Now, initially it was thought the Milan's criteria was very good, but subsequently it was felt that Milan's criteria is too restrictive, and we are losing a lot of patients who actually could have a better survival rates who are outside Milan criteria. And therefore, the other criteria which have been extended to is the UCSF criteria, which we say about figure of 8 and up to 7 criteria, and also Japanese use the Tokyo criteria and the Toronto criteria. Majority are similar in their numbers, but apart from the criteria, apart from the size of the nodules, the number of nodules vary. For example, in the Milan's criteria, we talk about any 3 nodules, the largest nodule not more than 3 centimeters. But in the extended UCSF criteria, you have nodules up to 5 centimeter, 4 and up to 5 centimeters, and the total volume not more than 7 centimeters. Similarly, up to 7 criteria is similar. Not total volume should not be more than 7 centimeters. So all these criteria, which has extended the usage of the liver transplant in the HCC patients. And there's also another one called Metro 2.0 ticket based on the size of and the number of nodules. So if the size and number of nodules increase, the risk of recurrence also increases. So it is about matching those things, recurrence rate versus the size and the number of the nodules. Based on that, the different criteria have been used. Now, HCC is not the point of discussion for this topic, so I'm not going to dwell much on this. But essentially, what I want to tell you here is the HCC's liver transplantation is a definite indication, particularly if they fall into the BCLC-B. But also, as you have probably known, that these days what we're looking at is downstaging or stage migrating these BCLC-C also, as long as they don't have portal vein thrombosis, or if they have VP1 or VP2, in other words, the subsegmental portal vein thrombosis, tumor thrombosis. Even those patients, we're able to downstage them with the therapies like the TACE or even the chemotherapies, neoadjuvant chemotherapies, and then considering them for a liver transplantation. So the Milan criteria, as I said earlier, it was introduced in 1994. But really, it's MELD. It has been used by the UNOS, was introduced in 2002, which has actually changed the picture. The reason why MELD was introduced was to make sure that patients we have picked up, which are more severe patients, will get an earlier transplantation compared to the first come first serve basis. So that's why MELD. Since then, MELD has actually taken a lot of changes or implications to it, and now we're using MELD 3.0. MELD and sodium MELD has come up, and now we're using MELD 3.0, which includes the albumin and the sex as well in the MELD 3.0. So most of the transplant centers use MELD, sodium MELD criteria to list their patients, including our transplant center, which we rigorously use the MELD score and the child score, particularly the MELD score, which we use regularly. So coming back to the acute liver failure, as I mentioned earlier, the most common reason indication for liver transplantation in acute liver failure in India and in our population is generally the viral, particularly hepatitis B. But if you look at the American population and the UK population, it is the drugs, the paracetamol overdoses, which are the significant cause of the reasons for the acute liver failure related transplant indications. And one point I want to mention here is in acute liver failure patients, please do not get worried about enzymes being elevated. The ALT, AST, or the SGO to SGPT, even if they're thousands, it does not matter. What matters is their synthetic function of the liver, which is the albumin, the INR, in particular the INR, and the renal function and the encephalopathy, and also the lactic acidosis on the blood gas. So anybody who has actually got jaundice to encephalopathy within a 1 week, we call this hyperacute liver failure. Anything between 1 week to 4 weeks, we call it as acute liver failure, and anything beyond 4 weeks, we call it as subacute liver failure. So 4 weeks to 3 months, we call it subacute liver failure. So in that criteria, if you see that the patient has developed jaundice to encephalopathy, and they also have coagulopathy, they have hypoglycemias, they have renal impairment, creatinine is high, then those are the patients where we should consider liver transplantation. And I'm sure most of you do use this criteria called King's College criteria. If you don't, then please do use this criteria. And of course, there are exceptions to it, but most of the transplant centers, at least as a referral criteria to refer this patient for the liver transplant center, King's College criteria is universally used criteria. So I would recommend all of you to go through that King's criteria and then consider referring these patients for liver transplantation, particularly all the hyperacute and acute liver failure patients. The Alfred is a criteria which we do also use. It is a dynamic model which has got these different variables: the INR, the albumin, the encephalopathy, and the arterial ammonia. And although there is a lot of controversy about using arterial ammonia and how is it actually been calculated, and there are a lot of lab variations to it, but I think if I had to use ammonia in any particular setting in a liver failure patients, it is definitely in the acute liver failure patients where arterial ammonia does have a significant positive predictive value, particularly if the levels are above 180 nanograms per ml. So in acute liver failure patients in the intensive care setting, you need to make sure that you use all the anti-cerebral edema measures. We should make sure that there's no increase in intracranial hypertension. And you should also look for controlling encephalopathy, the infections, coagulopathy. You need to maintain the hemodynamic status. You should have a very low threshold to dialyze these patients, put them on hemodialysis or CRRT for these patients, and also consider any metabolic concerns like any electrolyte disturbances and hypoglycemia. So you need to address all these things to make sure the patient is stabilized before you go for liver transplant for these patients in acute liver failure setting patients. There are certain poor predictors for patients in ALF, and as I mentioned here, high lactates, high INR more than 6.5, creatinine being high, more than 3.5 are poor predictors, and these are patients where you need to really consider moving on very swiftly for liver transplant. I'm happy to share the slides if you want to, but in the interest of time, I'm not going through all these things in detail, but essentially all the poor predictors are in here: the encephalopathy, the high jaundice, and also the lactic acidosis and the pH being low are the important criteria. MELD score, I'm sure a lot of you know about MELD scores. So the different criteria of the MELD scores which have been used, and currently, as I said, MELD 3.0 is what we're using. Most of the smartphones do have the MELD scores to calculate. So anybody who actually has a CLD comes to the chronic liver disease patients. Important thing that we write down in the clocking notes is so CLD, when was index presentation of decompensation, and what are the other previous decompensations that he had? Like for example, you might have had a virus. You might have CLD patient might have presented with a viral bleed in 2012. So we write down CLD, the index decompensation with viral bleed in 2012, and subsequently how many bands or viral therapy, banding therapies that he had, or any further bleeds that he had. Then you also should mention about any further decompensations like ascites, encephalopathy, or refractory HEs, or recurrent admissions to the hospital. So those are important criteria to understand how the patient is behaving. And we also should mention about the MELD score, the current MELD score for these patients. So that gives a snapshot about understanding about these patients where this patient currently stands. Okay, so MELD score, as I said, is universally used throughout most of the transplant centers, which is a good system to or a criteria to gauge this patient, how severe, how sick the patient is. But there are certain conditions where MELD does not actually is very useful, and particularly in patients who actually have uncontrolled ascites. So in other words, they have reasonably good synthetic function, their coagulation and creatinine are good, but they have uncontrolled ascites. Patients with hepatic encephalopathy, frequent viral bleed, although they have reasonably stable synthetic function, frequent cholangitis, in particular patients with PSC, and hyponatremia, and other patients, other things which I have not mentioned is the, in fact, I mentioned hepatopulmonary syndrome, HCCs, portopulmonary hypertension, malnutrition, sarcopenia. In fact, there's been a consideration about using sarcopenia as one of the parameters in the MELD scoring system. So all these are MELD exceptions. So patients who are, although may have MELD of 10 or 11, if they have refractory ascites, or if they have encephalopathy, recurrent encephalopathy requiring hospital admissions, we should not wait for them to have a MELD of 15 or above to consider for liver transplantation. You should have a very low threshold to look for transplantation for these patients. So that's why it's important to understand that whenever you also mention about MELD, you also should make sure that you also looked at the limitations of the MELD system. And now that you know that these patients would need a transplantation, so why do we need to do a transplant? So transplantation primarily, as I said earlier part of my talk, is to understand that narrow window period where the transplantation is beneficial for the patient. So you don't want to do a transplant for a patient who is reasonably stable, not decompensated, is maintaining, is preserving his liver synthetic function well, he's got good muscle mass. Then we may not need to transplant immediately. You know, we can stretch this as long as you control the portal hypertension, you remove all the etiological factors. For example, the patient has got hepatitis B-related CLD, we give the antivirals, the hepatitis B antivirals, and then you control the portal hypertension, and they have recompensated, the ascites has disappeared. You may not need to do a transplant for this patient unless they develop any further complications or the MELD score is becoming higher. At the same time, you don't want to leave these patients too late, to an extent that they become sarcopenic, they have refractory ascites, they have encephalopathy, recurrent encephalopathy requiring recurrent hospital admissions. So those patients who have actually probably missed the boat. They may have developed significant HPS, or portopulmonary hypertension. So all these patients may have missed the boat. So it's important that we understand and plan for the transplant at the right window period. And that only happens when we know about these transplantations, we know about a CLD and what are the benefits of the liver transplant, and what happens if we don't do a liver transplant for these patients. Now, the important aims of doing a liver transplant is to improve their post-transplant survival, and not only just the survival, we also should look at their improving their quality of life. We want these patients back on their feet, back working, having a normal lifestyle. That is the most important thing, not just the survival, but also making sure that they have an improved quality of life. And the general rule that we follow is, if the 5-year survival rates of these patients is less than 50%, that means they would need a transplant. That means that's an indication for transplant. And the different criteria that we use for the transplantation. When do we do it? The transplant, as far as the MELD score is above 15. In fact, I would say in the Indian setting is actually around 12 is when we actually start looking for the transplantation for these patients, because Indian population generally do have poor muscle mass, and they don't do well if we wait for them to get further decompensation and become sarcopenic. So that's the reason why in Indian setting we generally start evaluating for liver transplantation if the MELD is about 12. But in universally, if MELD is above 15, is definitely an indication for liver transplant. If they have CTP score more than 10, if the child C score in particular, they're definitely yes. And if they have any serious quality of life issues, particularly in patients like in PBC who have intractable itching or pruritus because of the PBC, that itself is an indication for liver transplantation. And if you expect the survival rates without transplantation are less than 90% at 1 year, that's definitely an indication for liver transplantation for these patients. And as I mentioned here, the MELD score about 12 is what we actually generally tend to say as a criteria to refer the patients to at least for transplant center. And the patient has ascites, edema, hypalbuminemia, encephalopathy, jaundice, not settling despite the standard therapies, bleeding is full varices, raised INR, HCC. All these are indications that these patients should be under the radar of the transplant center, because once they start decompensating, they won't give time for us. And that's time when we need to swiftly act on these patients. And particularly it's important because as the poll survey says, what I understand is most of the African countries do not have the transplant setup or the transplant access. So for these patients, definitely it is very important that we get referred these patients at a very early stage so that we can work on stabilizing these patients and change the nature of their course of their disease. So that's why it's important that any CLD patient should be referred to the transplant hepatologist, and especially if they have any even index decompensation. So patients, particularly if they have recurrent or chronic hepatic encephalopathy, if they have refractory ascites, SBP, recurrent PHG-related bleeding, progressive malnutrition, sarcopenia, quality of life, growth issues, diabetic-induced nephropathy, hepatorenal syndrome, HCC. All these patients should be expedited for liver transplantation, and do not please look out just for the MELD score. If they have any of these complications, they should be referred for the transplantation at the earliest. Okay, and whenever patient gets referred for a transplantation, it is just not one person's job. It is a teamwork. It is a multidisciplinary team where the patient carefully gets assessed by different specialties, including the cardiology, pulmonology, max facts, including the psychiatrist, psychologist, counselors. So all of them have to go through it, make sure that the patient is meticulously prepared, the infection control has been looked after, the patient has been dewormed. So all these things needs to be taken into consideration. And only when this patient gets clearances from all these different various specialties, the patient gets listed for transplant. So we do have a rigorous multidisciplinary team meeting in our setup. So every Wednesday we do have this meeting in our transplant center, where the patient goes to all these various multidisciplinaries, and then gets discussed in our MDT meeting, and then we address out all the issues. So therefore, it helps us in optimizing these patients and also risk stratifying these patients who have got a high MELD score, or their MELD exceptions, or they're expediting. So we can look at the risk stratification. And also it gives an opportunity for all the patients to go through, understand about liver transplantation. So I think what is more important, as I mentioned here, prepare. So it is very important that we need to go through all these processes in a detailed way. Now, I spoke about the indications, when to do and why to do liver transplantation, but also it's important to know why not to and when not to do the liver transplantations, particularly if they have severe cardiac or pulmonary diseases, particularly portopulmonary hypertensions, or if they have significant cardiac diseases, because especially coronary disease is a significant disease. The reason I say that is we have patients who have significant burden on the cardiac status, especially at the reperfusion status. When we remove the cirrhotic liver and then you connect the new liver and then reperfuse, that's time when they're very high risk of having cardiac deaths and stuff. So it's important that anybody who's got severe poor cardiac function or pulmonary functions, severe COPD, not fit enough for an operation, we should not be considering them. AIDS, I think, is a related contraindication. I think if they have previously, about 20, 30 years ago, AIDS definitely was a contraindication. But now with the excellent drugs which are available, and if the viral load is well controlled, the patient has got very well preserved synthetic function, and the no manifestations of AIDS, all the HIV patients can be considered for the liver transplantation. In fact, in our setup, we did do transplantation of about 4 HIV-related HIV patients, and touchwood, all of them have been doing well so far in their post-transplant journey so far. And obviously, patients who are having ongoing alcohol abuse definitely should not be considered for liver transplantation. So obviously, HCC with metastatic spread, anything beyond the liver, so any macrovascular spread or any extrahepatic spread definitely should not be considered for HCCs. Uncontrolled sepsis, yes, and particularly in patients who have SBP, they have a very high risk of post-transplant death, so we should not be considering them. We generally give them 2 weeks of antibiotics and then retap it and then reassess, make sure they don't have sepsis on board. In fact, anybody who comes on board for we get called up for a transplant, any recipient, when the cadaver is available, we get all the all the sepsis workup for these patients, including chest X-ray, the urine cultures, urine CUEs, and the ascites and ascitic. If there is ascitic presence of ascites, then we tap the ascites, make sure that there's no SBP before we actually list this patient for the transplantation. So any intrahepatic cholangiocarcinomas, extrahepatic malignancies, fulminant hepatic failure with very high intracranial pressures of more than 50 mmHg, hemangiosarcomas, all these are contraindications for liver transplantation. The same thing which I mentioned here. Okay, so as I mentioned, timing of the transplant is very important. So patients with CLD and decompensation, you should start assessing for liver transplant. The very sick patients, as I mentioned earlier, if they miss the boat, they are very sick patients. They don't do well post-transplant. And if they do survive, they would need a lot of time in the ICU setting, which adds to the morbidity for these patients. So it's important that we catch these patients at a very early stages in their window period rather than delaying and missing the window period. So rule of thumb, as I said, is once they start having decompensation, you should refer these patients for the transplantation, particularly if the MEL score is about 12 and CTP score is about 7. And if they develop any of these complications, SPP, GIB, HRS, HPS, HCC, you should definitely consider these patients for transplantation. So it is a balance, as I mentioned earlier. Too early, we should not be doing it, but at the same time, we should not be leaving it too early, where you miss the opportunities of the benefits of liver transplantation. So how do we optimize these patients? If they are stable enough, then we will list this patient for transplantation. But if they do have any of these complications like acute kidney injury, hepatic encephalopathy, SPP, portopulmonary hypertension, hepatopulmonary syndrome, we need to assess them and optimize and stabilize these patients. So portopulmonary hypertension, if they have severe portopulmonary hypertension, what I mean by that is if the MAP is more than 45 millimeters of mercury, then that's a contraindication for liver transplantation. So moderate portopulmonary hypertension, which means that the pressures are between 35 to 45. These patients, we do give them sildenafil drugs to be vasoactive drugs to actually vasodilators rather to reduce the portopulmonary or the pulmonary arterial hypertension, then we consider them for the transplantation for these patients. So severe, definitely contraindicated. Moderate, yes. After optimizing them, we can consider for liver transplantation. Similarly, there's the same figure that similar thing that I showed. If they are about 35, then patients should already be listed for transplantation. If they are less than 35, you optimize them and then list them for transplantation. Hepatopulmonary syndrome, the reason why you need to stratify these patients is if they are very severe, yes, you can still consider for liver transplantation, but you should expect that they will have a long weaning period. And we had patients where we actually had to discharge these patients post-transplant on oxygen and on CPAP as well. And some of these patients require even the oxygen for up to 6 months post-liver transplantation. That's because that is the amount of time it takes for the lungs to remodel for them from the effects of the HPS or the portal pressure-related HPS. So it is not a contraindication, but you need to optimize these patients, especially when they have severe HPS, pulmonary syndrome. So I'm not going to dwell on all these things. As I said earlier, the recipient evaluation, we go through all these things in detail. Then only we consider for transplantation. And if any of these evaluations, they have any concerns, for example, the social worker might come and say to us that this patient doesn't have proper social setup, he's got poor compliance to the medications, or if this guy has got risk of recidivism, then we will say no, absolutely no to these patients with the transplantation. So it is important that you go through the multidisciplinary meeting, all the specialities, and then get all the assessment, and then get the clearances. If anybody says high risk or contraindication, we would not do transplantation. So you can imagine the amount of the workup that the transplant coordinator had to go through to get all these things assessed. So that's about the workup for the transplantation. So now that we have decided that the patient needs a transplant, and you have a donor or the transplant available with us, so there are certain things which we consider when we get a call for a patient from other hospital who says that they have the organ available. So then we start looking at the functionality or the characteristics of that the donor liver or the cadaver liver, the performance status. So for that, we use these kind of criteria called the cold ischemia and the warm ischemia, the perfusion times. So cold ischemia time is basically who is actually the patient is DCD, or the patient is donor circulatory disorder dysfunction. So in those patients who actually you use a artificial bypass to actually pump the blood, in these patients, if they in other words, the pumping of the hearts, in other words, the liver itself, whilst it is in the cadaver itself, is perfusing well, and from the time of the death till the liver gets recovered from that circulatory area, that is called as a cold ischemia. In other words, the liver is still getting perfused by the native circulatory system, and that time, from the time of death to brain dead patients to the time of the removing the liver, is what is called as a cold ischemia time. Warm ischemia time is the time where the liver is outside the body, outside the cadaver, and before getting plumbed or before getting connected to the recipient, that is a time called the warm ischemia time. The warm ischemia time, generally we don't, cold ischemia time, you can expect up to 8 hours. But warm ischemia time, generally we expect it should be less than 4 hours. Perfusion, as the name says, once you reperfuse, a perfusion, that's what we call as perfusion, and the preservative solution that we use for cadavers, you use the ultraviolet solution. We generally use about 4 to 5 liters of this HDK or IGL solutions, and we keep perfusing the liver to keep the toxins flushing out. And once you actually connect this liver to the native IVC, that's what we call as reperfusion, and that's the most crucial part. And as I mentioned, that's the time when the risk of even cardiac death happens. So the next test we always do for these patients using a transesophageal echo, so that we can actually look at the cardiac function of these patients at the time of the reperfusion. Now, GRWR is the ratio that we use for patients in living donor transplantations to look at how much of liver we can remove from the donor, and which is safe. Generally, we expect to have a GRWR of more than 0.8 is what the safe limit that we use, but sometimes we can stretch that limit even up to 0.5 per percent of the transplant of the living donor. Now, coming to the liver transplant surgery itself, I'll tell you very quickly in about next few slides about how we actually connect and what we need to do. If you do have the opportunity of watching liver transplant, I would recommend all of the transplant hepatologists, or even though a medical side, we should watch the transplant surgery, how it is done, because that actually adds more value and gives confidence for us when we explain the patients about liver transplant. So there are two types of transplant, as you know, the cadaver, the deceased donor liver transplant, or the living donor liver transplantation. Okay, so that's what the major things are. So the different types of grafts which are available, particularly for hepatectomies, particularly for patients who are actually living donor transplantations. So if you look at the left lateral segment, it is 2 and 3. Left lobe, we talk about 2, 3, and 4. So generally, pediatric population, we do take the left lobe of the liver from the parents, mother or father, and then we can donate the part of the liver to them. Okay, so right lobe is, as it says, all the four segments, is segment 5, 6, 7, and 8. Extended lobe, right lobe is 5, 6, 8, and also the middle hepatic vein. So basically, this is just to make you understand, particularly this is helpful for patients when we do living donor liver transplantations. How do you actually do it? So living donor, as the name says, we take out the 5, 6, 7, 8, the right lobe, and we leave the left lobe to the donor itself, and we remove the right lobe and then transplant it to the recipient. Now, this is the order of anastomosis that we do, and it's important to understand. So basic common sense, really. So we first reconnect or plumb the outflow tracts first, then comes the inflow tracts, then comes the biliary anatomy. So this is how it happens. So outflow tracts, first the hepatic veins and the IVC gets connected. The middle hepatic vein, the inferior hepatic vein, they all get connected. So the hepatic veins get connected first, and then the inflow, the first the portal vein, then the hepatic artery gets reconnected, and then the biliary anastomosis. So that's hepatic vein anastomosis that happens. Some pictures which I'll just quickly go through because in the interest of the time. Because I think we don't have surgeons in our audience, so that's why I'm not dwelling much on this. So next comes the portal vein. So this is the donor portal vein, and this is the recipient portal vein. So that gets anastomosed. So even patients who actually have portal, I wouldn't say portal cavernous, but they have significant anastomosis to the portal vein. Not necessarily that you have to look out for the native portal vein, as long as you know that there is a shunting process that is a connection to the donor and the recipient portal system. That's absolutely fine. So this is a different types of anatomies that we use, but I'm not going to dwell much on these within the rest of the time. And then hepatic artery anastomosis, and that's the most crucial part, because hepatic artery anastomosis, if it doesn't happen properly, there's risk of developing hepatic artery thrombosis, which can be life-threatening in patients with post-liver transplantation. I have a few slides about hepatic artery thrombosis, which we'll discuss in a bit. So they can have different types of reconstructions. This is a standard one. You actually connect the donor hepatic artery to the recipient, but sometimes you connect the donor hepatic artery directly, graft it to the aorta itself. Sometimes you even create a little conduit proximal to the celiac axis for patients for the liver transplantation. So biliary anatomy, for all the patients with, particularly for living donor transplantations, we do a CT for volumetric analysis. We also look at all the arteries and the veins, and also look at biliary anatomy, because if you have better road map of all these structures, all these tubes, the biliary structures and the vascular structure, it makes it so much easier when we do a transplant, or when we actually open up, before cutting the knife. If you know all this anatomy, it makes it so much easier when you actually are operating these patients. So patients with PSC who also have biliary the CBD being involved because of the PSC disease itself. For those patients, we need to consider the Roux-en-Y operations for these patients. But general standard operation is duct-to-duct anastomosis, as you have seen here, whether it's a single duct or double duct proximal ducts, or double duct distant duct, as it says here. So different anatomies, it's important that you talk to surgeons. Especially this anatomy is important because if patients develop any post transplant anastomotic strictures, it's very important to understand the anatomy. So I always go back to my surgeon and ask them to draw a diagram about the vascular anatomy, the biliary anatomy, how they actually connected the ducts, so that when I actually put a cholangiogram, I should not get surprised by the different anatomy. Okay, so living donor, I think we discussed about it. So living donor transplantations particularly are very helpful in settings like India because of the close-knitted family, and also because we don't have significant cadaver generated or cadaver-led programs. So if you actually look at the transplant volumes done in India, 70 to 80% of the transplants are done through living donor transplants. and only about 20-30% are done through cadaver transplants. I think for the African population, if certainly patients are getting referred for transplantation to India, so obviously there is no option of cadaver, so we only have to consider living donor transplants. And all the liver transplants that we have done in our setting, from Africa, from Middle East, I mean anywhere from outside India, all of them have been living donor transplantations. So we always recommend them to come with 2 or 3 potential donors along with the recipient. Okay, so I think I'll skip this slide for the interest of time. I think we discussed enough about the transplantation itself. So let's discuss about the complications of the liver transplant, or what are things that we need to look out for, and how do you actually monitor these patients post liver transplant. Now,
Naveen, if I may interrupt, excuse me. Thank you.
Sorry.
This is really quite interesting, but we've reached the end of our time. And so
okay.
I'm almost wondering, I would like your opinion, where's a natural break point? And should we keep post-transplant management for another time, potentially?
Yeah, we can do that.
It sounds to me like a big topic. And
it is, yeah.
There'll be a lot of questions about that from our group, since, as has been noted, patients are coming back to us for management. Yeah. So that might almost be a session unto itself sometime. What do you think
absolutely.
about that?
Yeah, absolutely. I mean, as I said, post-transplantation is a very important topic. And as you rightly mentioned, I think a lot of patients do come back to Africa. So I think we should have another discussion about it. And I would be really happy to discuss this, because it's important for you. So whenever I send a patient back to the Africa, I would like to know that that you are also empowered with all the information that needs to be done to look after these patients. So I think we should have another session about it. I agree with you.
So I think there's some questions, at least one question in the chat from Kinfei about what is your, really about indications. And I think a lot of our colleagues here have a lot of questions and thoughts about sending patients who can afford to come elsewhere for a transplant. Those of us who don't have a program in our country, are we sending them too early? Are we sending them too late? But the question from Kinfei is, what is your practice for patients with HCC with portal vein tumor thrombosis? And maybe you could just recapitulate for us, which HCC patients should we be sending and which should we not be sending?
Okay, now very important question, to be honest. So HCCs, I think we all should use the Barcelona staging criteria, which I'm sure most of you guys use it. So if they are BCLC, I assume everybody is familiar with the BCLC staging, the Barcelona staging criteria. So if they are BCLC C, in other words, they have multinodular HCCs, lesions more than 7 centimeters. If they have portal vein thrombosis, particularly the main portal vein thrombosis, and the right and the left hepatic vein thrombosis, those are all contraindications for liver transplantation. We should not be going for liver transplantation for these patients. Instead, for these patients, we should consider the treatments like the systemic chemotherapies. Either you go with the sorafenib or the lenvatinib, or the newest kid in the block is the atezolizumab and bevacizumab. And I'm sure most of you are aware that there's explosion of the chemotherapy drugs regimes that are happening in the HCC market, particularly in the BCLC-C criteria. If you look at BCLC-D, absolutely it's a supportive care only, so you don't have to consider, we don't even have to refer these patients. In fact, we had patients who have been sent to us in a BCLC-D stage. In fact, as latest as just last week, we had patients from Kenya who got referred to us with the BCLC-D. In fact, I sent him back pretty much straight away. The next day itself, I sent him back saying, look, I'm sorry, there is no possibility of giving any treatment which are going to be curative. And I'd rather him spend his time in his back in his country. So I'm sending him back. So I felt very sorry that he had to travel all the way all the way to us to only be to send him back to his native place. So BCLC-D, definitely no. BCLC-C, yes, we can consider TACE and a TARE, and also for systemic chemotherapy for these patients. Yes, we do have these patients who come to us. BCLC-B, who have multinodular lesions but not having portal vein thrombosis, yes, we can downstage them and then consider them for liver transplantation. But BCLC-A, definitely all of them should be considered for liver transplantation or resection if the rest of the liver is well preserved and they have good performance status, and also if they have no significant portal hypertension. So I hope that
Now,
answers your question.
yeah, that's an excellent answer. And I want to follow up and ask about, some of us have resources available, such as RFA or TACE, for borderline liver lesions. What's your view about those therapies happening on another continent from you? And then if the patient seems to have had a response, then sending them to you. Where would you want to get involved in that whole process?
Yeah, I mean, if I had to answer this question straight away at the very, very beginning of the journey of the patient, because again, as I said, it is a multidisciplinary team approach, and the more we know about this patient earlier, we'll be able to better manage these patients rather than being present at a later stage. Now, as I told in my talk earlier, that the HCC management has been shifting. We are shifting more towards the left side of the panel of the BCLC. So what we call about is a stage migration that is happening, or we even downstaging these patients from BCLC-C, we're able to downstage to BCLC-B, and then even consider for liver transplantation for these patients. So, so yes, patients, particularly HCC, are on the waiting list for a long time. We actually do a bridging therapy with either giving RFA or even TACE, downstage them, and keep them under the transplant criteria, and then consider for liver transplantation. So if you do have any patients with any SOLs, liver lesions, please do talk to us. We all discuss and then come to a consensus and see what is the right thing, depending upon on the availability of the services that you have, whether you go with TARE or TACE or RFA, depending on the size of lesions, we can we can suggest what is the right treatment modality for these patients, downstage them, and then consider for liver transplant.
Now, a couple of other great questions here. How about using HCV positive living donors?
Good question, and that's always a mode of contention because HCV related donors, we can only use it for HCV related recipients. But again, you have to go through ethical approval for this. To me, the logic says, you're only giving HCV to a HCV. And the fact that now we have excellent antivirals, HCV antivirals, post liver transplant, treating HCV has become like a cakewalk. It's as simple as giving these drugs for 12 weeks to 24 weeks, most times 12 weeks, and you're home, in terms of eradicating the virus itself. So yes, HCV positive donors, we can give to HCV recipient, but you have to get ethical approval for these patients.
Question here about the impact of travel time and related transportation issues on transplant outcome and decision to transplant in acute liver failure.
Acute liver failure patients, I think it will be very difficult for you guys to transfer the patient from Africa to here, because obviously time is essence. But I think if they start developing encephalopathy, for sure, they don't have much time. So you should consider for transplant options locally. In UK, what we used to have is a super urgent listing. So anybody in all the transplant centers, whenever you have a patient who's been listed in the super urgent listing, they get the highest priority. So wherever there's an organ available throughout the country, they take the top priority. Similarly, in India also, we do have the super urgent listing here. So we do get these patients on the listing for an urgent transplant. But I think it's a difficult question to answer, particularly in African countries. If you don't have a liver transplant unit available next to you, then I think the patient will be in a big trouble.
Then a question here, how should we manage surprise presentations at end-stage liver disease? Skinder says that's one of the cases he had to present, but I think all of us here, we see patients who present with some serious decompensation, and it's the first clue anybody has that they have liver disease. So any particular advice for that situation?
I think it's a big. I mean, it's a big question to be answered. To be honest, see, most of our patients with chronic liver disease patients, they only come to the hospital only when they're decompensated, either through the variceal bleed or through ascites or encephalopathy. Most often it is the ascites, and next often is the variceal bleeds. So I think we need to understand that once you stabilize these patients, that you stop the variceal bleed or you have optimized the ascites, that's the time when you actually start referring these patients for liver transplantation, because it is very important to understand that once they develop decompensation, once they develop CLD with portal hypertension and they develop decompensation, it is a chronic, progressive, and irreversible condition. So you should start sensitizing these patients for liver transplantation at the first decompensation whilst you stabilizing this patient. The other thing, other ways of actually picking up these patients is by doing active surveillance for these patients, particularly with hepatitis B patients. All these hepatitis B patients should be under surveillance. They should be, that partly the responsibility, in fact, not partly, majority of the responsibility should be done by the government of our countries to sensitize these patients, identify this patient population with hepatitis B and C, and then start doing surveillance for these patients. And as you know, HCCs can happen in hepatitis B and C, and even including NASH-related patients in non-cirrhotic livers as well. So don't wait for these patients to develop cirrhosis. Then you start surveillance for HCCs. Even in non-cirrhotic patients, if they have hepatitis B or hepatitis C and NASH, you should start doing surveillance for these patients. And that impetus should come from the government also, so that we identify these patients when they develop CLD. But my whole point I'm trying to say here is, once a patient has got chronic liver disease patients, please start looking, assess these patients, use these MELD scores, the child scores, and also look at the MELD exceptions also. You have great tools to understand this patient, and then refer these patients at the earliest, once we know that these patients is start kind of slipping through the net, or having a slippery slope. That's the time when they should be referred to us.
So about the government advocacy, we'll ask Haile Mikhail to give a talk on that on another day, because I think it's heavily involved. So we're going to finish up here because we're way over. There's one question. I'll ask you for a one-word answer. The question is, with regards to endoscopic prophylaxis management of varices, could it induce problems with thrombosis before transplant?
Sorry, say again, sorry. Could that induce?
So would endoscopic variceal ligation of varices cause problems for a transplant?
No.
Okay. So, and then I'll mention the comments from Akwi and Benyam about learning from each other and developing transplant resources on the continent. And I also think that's a great topic for another session. So thank you both for those comments. And I think we'll wrap it up now. Haile Mikhail, do you want to have the last word?
Yeah, thank you so much, Dr. Naveen. I think we need to have these patients are sent to abroad, for example, to India, as had been the question. And sometimes it's difficult to know who are following, are these individuals following in that country, are well equipped with such education, like in an area where that's why we include poll questions, the capacity for, like, there are no transplant pathologists in many centers, and what's the capacity of following these patients, even which centers have this tacrolimus level, or like we had such difficulties, especially also in Ethiopia, for like we had renal transplants, now they are having follow-up of this level. So sending them abroad, and it's important to also improve the capacity of the countries which are sending actually patients. And then, as Akwi has mentioned, probably another topic, building capacity. I think the Indians have been helping, for example, the Sudan to establish a liver transplant center. So supporting each other in such a way will be important. I think the next topic, which includes the case presentation and the complications. We have the question in the case probably by Dr. Skender, where some difficulty of like graft dysfunction versus acute rejection or acute liver failure. So probably in session 2 should be continued from, I think that's better if you have another session with you with the case and also how to follow patients. And then a discussion point should be included to make it complete.
Yeah, so one just last word I want to add here is, so patients who actually had transplant with us and they went back to the countries, like for example, we had patients from Nigeria, Kenya, and Mozambique and Tanzania. So what we did was we established a group with the local physician, local gastroenterologist, and us, and we established a group, a WhatsApp group, or some sort of a connect where we all used to discuss. So that's how we used to do. And Mark is one of the consultants from Nigeria who used to send patients to us regularly for transplant. So if he's on the in the panel here, so he can also throw some light how he felt about that kind of a connect or the setup that we did. But it's important to have the connect. So it's about hand holding each other to make sure the patient is getting better.
Yes.
Hello. Hello.
Hello.
Hello. Yes. Can we talk? Hello.
Eskinder, I think we want to save the case for next time because we're well over.
Yeah, I just wanted to ask about a discussion about the legal proceedings of transplant also, because I have faced some challenge with this patient of mine. If someone can discuss these issues.